with where we were at yesterday. We were talking about type 1 diabetes yesterday. Major treatment for that, obviously, all of our insulins. So today we're shifting and we're going to be looking at type 2 diabetes. Type 2 diabetes, remember, that's that progressive decline in beta cell function. So you have slightly different treatment because the etiology is slightly different. Previously, this was called our non-insulin dependent or adult onset diabetes. It's a little bit of a misnomer just because some of these patients may still end up on insulin, but if that helps you to keep them separate between type 1 and type 2 for the treatment, that's a way to remember that. Moving on to the next slide and the next one. So our group, we have primarily the overview. This is the treatment algorithm here. So we're just going to give a brief run through for those of you who like charts.
And I want to tell y'all, this is going to be on your exam. So please pay attention, and I'm going to reiterate it again. We're going to hear this several times because this is how you're going to choose, like your therapy when we're talking about oral, right? So just like we just had the recap of, you have your insulin and us talking about basal bolus. This is like the way that we're going to stack and build for our type 2 diabetic patients, okay? So very important slide, start, circle it, all of the things.
Okay, so for type 2, looking at this flow chart, again, we're just doing a brief overview so that you guys have an idea of where these medications fall into the treatment algorithm when you break them down later. So step 1, up in that top left, diagnose and set goals. Luckily for type 2, it's the same as for type 1. So we're primarily looking at that A1C, so greater than 6.5, that's your diagnosis criteria. And then the goals are also the same as type 1, so nothing different to remember there, just dependent on the patient whether you need to be less stringent or more stringent. So step 1, done, you got your diagnosis and set your goals. Now step 2, you need to do your treatment. So you have a couple options. You have monotherapy, dual therapy, or just going straight to insulin. For most patients, standard start, you're going to start off with monotherapy, and for that, you're always going to go with metformin. That's your standard monotherapy that you're going to start with for all of your patients. Now, in some instances, you might need to do dual therapy. So starting with more than one drug. If the patient has an A1C that is 1.5% above their target, so whether that's your 7%, your 8%, if it's 1.5% over that, you can start with dual therapy right off the gate. So that just means metformin, and then you're going to have to choose one of the agents down below. And then finally, your third option is your insulin. So if you have a patient that comes in and are highly symptomatic, or an A1C in the double digits, so greater than 10%, straight off the bat, you can start with insulin. You don't have to wait for monotherapy or dual therapy to fail if they have an A1C that's already in the double digits. And then also just keep in mind that this is a progressive condition, so your patient might be on monotherapy, might be on dual therapy, and they may end up on insulin anyway. So with that, you need consistent follow-up. So if you're starting dual therapy, or if you're on monotherapy and their A1C is still above goal after 3 months, so the guideline there is 3 months for that follow-up, you'll have to add another drug, and that's when you have to start looking at comorbidities in order to decide which add-on you're going to do for the dual therapy. So two questions you can ask are, do they have ASCVD risk, high weight loss needs, or do they have heart failure or chronic kidney disease and some other comorbidity? So if they have ASCVD, a high risk for it, or they need to lose weight, your add-on of choice is going to be a GLP-1 and then an SGLT2 inhibitor. The reason that we're going with those two is just because those have some cardiovascular benefit. They can reduce heart failure hospitalizations, so those are like your preferred if you have a patient with those risk factors. And then on the other hand, for heart failure, chronic kidney disease, same thing, just starting with an SGLT2, then a GLP-1. Then you also have the options for the DPP-4 or the basal insulin towards the end. Again, just general rule of thumb there that those should have some cardiac benefit when you're choosing your add-ons. And then last thing, if you're choosing for third options from the algorithm, you can mix and match from different classes like the sulfonylureas or the TZZs, the DPP4s, the SGLT2s, DP1s. Just one major contraindication is no DPP4s with GLP-1s. So those two do not mix regardless of whatever other meds you're mixing. Those two will not mix. So just to recap, monotherapy, metformin, dual therapy, metformin plus another agent based on comorbidities. You can mix and match as needed, just no DPP4s or GLP-1s, and then remember these patients might eventually need insulin. And then we have one slide left.
Hold on. That was the best that I've ever had to be taught, so thank you. Okay, that was amazing. So I don't have a whole lot. What I want you to look at is you see down at the bottom, and you'll hear different things as the guidelines keep changing because we're getting more information about GLP-1s and SGLT2s. So it depends on where you are in your career as to how you're treating your patients. What they're starting to think about now is for some of your patients who have the ASCVD or the weight loss need or heart failure CKD, we may go automatically to the bottom and not necessarily try to put them on metformin. So that's something that's kind of going back and forth because there's several benefits that we're getting, right? We're going to get that diabetic relief, but then we're also getting to tackle that comorbidity. So you may see where that shifts from the monotherapy of just metformin. For your exam, remember that's how we talked about how this was brief, right? So your monotherapy with your metformin, unless they have that higher A1C or they're symptomatic, then that's whenever you're going to put them on insulin. You're not going to wait. So that's your type 2 person who has insulin now, right? And then your dual therapy, metformin, and then you can pick one. When we start to go through these, you'll see that those things that are kind of towards the bottom, your TZDs, your sulfonylureas, some of these we don't use as much anymore because we keep creating new drugs that are better with less side effect profiles, less interaction. And then when you get down here at the bottom with your ASCVD, when you get down here at the bottom with your ASCVD and your weight loss, you can pick either one, GLP-1 or SGLT2, but whenever you're looking at your heart failure, your CKD, that's just you specifically going to your SGLT2 first, and then you can either add or you can drop. It depends on how your patient is doing. When I ask you for the exam, I'm not going to get past that second thing here on the bottom. So I'm not expecting for you to be like, oh, DPP4 and basal insulin, right? But if you did have to do this, know that you couldn't add these two things together, right? I still can't do that. Okay, so when you're stacking, you can always stack multiple things. Again, on the exam, once it gets on that bottom one, I'm not going to get to DPP4 and ask you because that's like you're going to have that patient split at that point. Okay, that's not going to be your problem. All right? So I'll get to maybe potentially that second line thing and then understanding the things that are in red and remembering that you can't check their A1C before that 3 months. If you're checking before that 3 months, the drug hasn't had enough time and that blood cell hasn't had enough time, so your A1C is going to be an inaccurate A1C. Okay? Also keep in mind if somebody has blood transfusion. They had a blood transfusion, that's not their A1C, that's the person that they got their blood from. Okay? So keep that in mind also. Alright? Because that's where our A1C is coming from. So every 3 months, if I came in before and I'm like, well, doc, my glucose levels are still trash, I would expect that because it's before 3 months, we don't know what's happening yet. Right? So we have to wait that full 3 months, don't change anything unless you're having a bunch of hypo or hyperglycemic events, don't change anything based off of just that A1C before the 3 months comes up. Okay? If you're responding to numbers, that is fine. But if you have to respond to your A1C, full 3 months of treatment first. Okay? So every 3 months you'll do something, and then if you need to, you'll change it. If you don't need to, leave it. Right? It's fine. They're fine. Okay? That was really, really good. Thank you.
Here's another chart. I recommend just memorizing this one.
No, don't. I actually say that and I tell people this is a summary of what you guys are about to go through when we talk about these drugs, okay? So what this is telling you is all of these drug classes, right, that we're talking about. We're going to talk about every single one of these drug classes. And then these are the times where you can use them. And then a big thing that we talk about, these are some of our side effects that you're typically going to see. And when you see them more in some drugs, right? So like I was telling you about insulin. So this is a good summary for you to review. If you remember by looking at the slides, that is pertinent enough, okay? It's not like I would go to this and be like, hey, let me ask you a question about how much money something costs. Like, I'm not asking you that, right? Remember, I'm sticking to what are my medications, adverse effects, clinical indications, things like that, okay? So this is just a good summary for you to go back and look at just like these side effect type things, and then the renal adjustment. We already talked about what you're using in ASCVD and heart failure, so you don't need to look at that again. So this is just saying, hey, I'm more likely to see weight gain when I'm using a TZD, insulin, or a sulfonylurea. You're going to see that on those slides too, as an adverse effect. Okay? So this is a summary slide for you to look at specifically kind of these things right here, these adverse effects that we're going to talk about. Okay? So don't remember the whole chart. It's for you to go back.
All right, tough follow. Here we go. All right, so that first slide, pharmacology. That is what we're doing. So this right here is a good sum up slide. I'm sure similar advice to the last one. It's not necessarily that you remember everything. Something that I do when I look at stuff like this, where you're comparing a lot of stuff, look for things that stick out or are different. So some of the stuff I saw, biguanides, just lifestyle changes. If you can look at their A1C reductions, both of those things are actually pretty similar in how they work. Looking at your mechanisms of action, a lot are similar, a few stick out that are different. Contraindications, again, you'll see a lot of, a big common thread here with these is renal and or liver insufficiency. So keep that in mind, especially going through these next few slides as to things that would kind of make those drugs be contraindicated. All right, so first thing, I'm going to start out with a quote here. People will forget what you said, people will forget what you did, but people will never forget how you made them feel. So that's Maya Angelou. I can't give you a ton of great memory tools, but I can make you feel really good about these next 3 slides. So let me get my notes here. All right, everybody close your eyes. Imagine that you are in the Baltic Peninsula and you are in the Rocky Hills of, let's say, Bulgaria, and you're looking and you see some flowers. It's very likely that what you're seeing is the French lilac. And one of the interesting things about that French lilac is it contains guanidine. So if you look here at this first class, guanidines, this flower was actually used during the medieval times to treat people with what was then polyuria. So again, that early diabetes before it had a name. The origins of metformin goes back very, very far. And any material I reference that's not included in the slides, I can furnish upon request after this. So, So first thing, diabetes is super important to me. My cat has diabetes. I'll send out that picture later. So I'm fighting diabetes every day of my life. Let's cure this together. All right, anyways, to our material, metformin. This is a very, very common drug. A lot of people are on. You'll notice here, so through the mechanism of action, it pretty much attacks sugar. It attacks sugar production. It enhances insulin sensitivity. It also does reduce how that sugar is absorbed, and it also helps those tissues take up the glucose that it needs, so it's not just hanging out in the blood. Big thing here, like with everything we've covered in any of our blocks, this is our first line, aka our big gun for type 2 diabetes. So again, like you saw on the flow chart a few slides up, you're really going to want to start with this one and then add to it. It adds a cardiovascular benefit, and a lot of times people with type 2 diabetes are going to have those comorbidities that we should consider. Another use for metformin is PCOS. We will learn about that next semester. Dosing. So cool thing about metformin is it can be used in kids. If anyone's ever seen Family Guy, there's a child named Diabeto. And Diabeto really, really wants a cookie. His mom says, no, you need to roll back to the kitchen. So think about Diabeto, think about metformin, and just remember these kids are getting bigger every year. And we can use metformin for that. But again, so that the first summary slide we looked at, I mentioned the contraindications here. A lot of these things do affect your kidneys. So elderly patients with renal dysfunction, you're going to want to be cautious with how you dose them. You do not want to max them out on metformin. Right there. All right. So continuing on with metformin, like I mentioned, it is renally secreted, and it goes through the glomerular filtration. Some adverse effects that you may hear from your patients, you can potentially have GI upset. So with a lot of our drugs here, you start lower and you add it to tolerate. Also encourage them to take it with meals to minimize those effects. This is a PO drug. Other things to counsel your patients on, they might have a metallic taste, and this can also decrease B12 absorption. So keep that in the back of your mind for potential side effects, comorbidities that your patients might have. Good thing about this is relatively safe, low risk of hypoglycemia. There are some instances of lactic acidosis, very rare, and I'll touch on that in just a second. This is weight neutral, which is encouraging for a lot of patients because, like we mentioned yesterday, gaining weight, it's very hard to lose whenever you are being treated for diabetes. Looking here are contraindications. This is renally excreted, so some labs you're going to want to do. Before this, you're going to look at their serum creatinine and their creatinine clearance as well. So it is slightly different for males and females, but just make sure that you monitor that, and if it is if their serum creatinines above these levels, it's contraindicated. And again, that increased risk of lactic acidosis, or with a decreased creatinine clearance, liver disease, alcohol abuse, sepsis. So some of those might be important conversations to have with your patient.
Okay, so normally, you know how I say GI stuff, that's like every med, right? With this is a big thing with metformin to the point to where we have immediate release, we have extended release. So sometimes you may have a dose that you want your patient on, and you have to break it up to where they're taking it several times a day. A lot of your patients on metformin may stop it because they have the diarrhea, the upset stomach. So it's like a big thing for you to make sure that you counsel them on and talk to them about, right? Because if it's not working, I need to give them something else to make sure that they take it. I always tell you, if the medicine stays in the bottle, it's not helping, right? So you can change to an extended release, eat it with food. There's several different ways for you to kind of get around it. Break up that total daily dose that they would be taking into multiple doses. It's more inconvenient, but it's good for them because their belly isn't hurting, right? And they're not going to the restroom. So that's a big, big side effect when we talk about our metformin. With the serum creatinine, if you just remember creatinine clearance for this, that is good enough when we're talking about like exam purposes, okay? If you see a number, it's not a big number, all right?
All right, well said. So going down, as you can imagine, with how contrast works during scans, it does filter through your kidneys. So if your patient has to have a CT or anything like that, or receive any of that contrast, you're going to want to hold that metformin. And then even after that contrast is given, you're going to want to wait a little bit longer for those kidneys to rebound and be better able to filter that drug. Cimetidine, it's our H2 agonist. Typically, it'll be for GERD, heartburn, anything like that. Again, a lot of these patients will have similar comorbidities, so this could be something they're on. That's also going to compete for renal tubular secretion, and that's going to increase those metformin levels. So make sure you are aware of what your patient is taking. Monitoring, pretty important here. Again, this drug's typically a low threat. However, some of the bad things that happen can be really bad. So you're increasing lactic acid, you can decrease tissue perfusion, and that can lead to some pretty severe problems if it's not noticed or monitored. And like we've talked about in other classes, diabetes can mask a lot of other symptoms, so it might kind of cause a delay until the problem is pretty dire. And then again, liver disease and chronic alcohol, you should always encourage healthy habits with your patients. All right.
So, in an emergency situation, do you think that I would hold imaging if I suspected that somebody was on metformin? We do it, and we hope for great outcomes, but they're going to be in the hospital, so it's okay for us to take care of that patient at that moment. That does happen. Testing purposes, you're going to try to separate it out, okay? So you're not trying to do one with the other, okay?
All right, pool table. For a lot of different forms of metformin, you see here the big things are immediate release and extended release. We have the Reamet, that's a solution, and something. So you can see here with the starting dose, they're dosed at different times, so consider that with your patients.
And then don't remember I want you to make sure that you understand you have a solution and you can relate that to the fact that kids can take it, right? Because remember, a lot of my kids can't swallow pills. And these aren't small ones. They're pretty big depending on which dose you're giving your patient, okay? So kind of remember I have a solution. I have a solution that should help you in that question that you have kids that can take it ourselves. So from this side, just understand IR, XR. When do I use my XR? What's the big side effect that they can have? GI. So I can go to my XR if I didn't have them on an IR. Okay? So a lot of times it's beneficial to just start with XR, but some people we give them IR and they tolerate it just fine. Okay? Thank you. That was good too.
Okay, we're going to talk about some incretin hormones or peptides. So the incretin concept is that if you're given glucose orally or intravenously, your body's going to respond differently because when you're given that orally, it increases the amount of insulin that is secreted. So then your insulin response is higher through oral glucose than it is through an IV glucose formula. That's because of these peptides. So these are traditionally secreted by your gut when you eat a meal, which then stimulates that insulin response. Is there anything else on this slide? Oh yes, so the DPP4 is actually an enzyme that breaks down all your peptides. So as you can see on the top, we have the DPP4 inhibitors, which is the drug that we would give to slow down the degradation of our peptides.
So remember, I make my drugs to either mimic what my body is doing or to go against what my body is doing. So when we talk about these, GIPs, GLPs, and our inhibitors, like DPP4 inhibitors, okay? So that's what we're going to start talking about for this question.
So these are your agonists, as she said. These are the ones that are mimicking that response. So you have your GLP-1s and your GIPs secreted by different cells in the gut when you eat a meal. The GLPs are your L cells. L goes with L, and then your GIPs are your K cells. And they both have a similar function. However, your GIPs actually increase glucagon while your GLPs lower glucagon, but both will stimulate insulin release. So the risk for hypoglycemia is pretty low with these compared to traditional insulin therapy.
All right, so both things are big ones, minus I didn't go this one, looking at the fact that with your dips, you don't have the motility, the GI motility being affected by this one, okay? So those are the big things. Molded things are bigger focus with this, okay? As we talk about PO.
This is just a summary slide of what we just talked about. So yeah, this is a slide to kind of determine whether or not you're using an agonist or an inhibitor. Your agonists tend to have more efficacy, but they also have more side effects, like more drug reactions. So if it's a patient that doesn't tolerate meds as well, a DPP-4 inhibitor would be better. But the GLPs and your GIPs are going to have a weight loss. So the first one's with a weight loss effect.
So summary slide of what we're about to look at in more detail on the slide.
All right, so moving on to our DPP-4 inhibitors. And as Scott already stated, this enzyme degrades the good guys, the GLP-1 and GIP, so we're inhibiting that enzyme in order to increase our insulin secretion and decrease that glucagon secretion. And it has no effect on gastric emptying and satiety. Orally active, does that mean that it's not as effective at first pass metabolism?
Well, this one means I can take it by mouth versus when we look at our other subcues.
Okay,
So
so
if
it's
you look
P.
at this one, same thing that it's showing you, right? Versus my subcue.
So this is PO.
Yeah.
And for type 2 diabetes. And if you can go forward one slide, please, just so we can look at the drugs we're looking at. So as you can see, they all end in gliptin. And as we discussed, they're all out of PO, but we're going to go back one slide, but these are all the drugs we're looking at. So adverse effects, this is weight neutral, much like metformin. I think those are the only two drugs that don't affect weight. There's a low risk of hypoglycemia, and it may be associated with pancreatitis in bold, so I put my P's together. Sitagliptin or saxagliptin has an increased risk of infection. They start with S, so for me to remember, I'm thinking S for sick. And saxagliptin also can worsen heart failure, so caution with patients who are who have heart failure. Dose-related reduction in absolute lymphocyte counts as well with saxagliptin. And then side note there, any patients with poor renal function have to have their doses adjusted with the S drugs and alogliptin. And then our drug-to-drug interactions, we have to decrease that sulfonylurea by 50%. I don't think I remember talking about that drug. But as we already stated before, no DPP with our GLP, so no dip with GLP is what I'm saying. All right, so the chart here, what sticks out to me, I know we're not remembering doses, but the elderly dose I know is lower than the non-elderly dose, so that's noteworthy. As far as comments, saxagliptin and linagliptin are both CYP enzyme substrates. And I know I mentioned the dose adjustment for patients with renal problems, but we don't have to worry about that with linagliptin. Or renal impairment either, so that's good. I think that's the only thing noteworthy with this one.
All right, so we're on to GLP-1 agonists. They stimulate the GLP-1 receptors, which increases production of insulin secretion in response to high blood glucose levels. Thanks to Matt, I now know what postprandial glucagon secretion means. So that's post-meal glucagon secretion. Slows gastric emptying, reduces food intake, and stimulates beta cell proliferation, preservation, and function in animals. And the clinical use is type 2 diabetes and may be considered if metformin is contraindicated.
So for you, when you're thinking about this, not something that's first line, right? But this is what I was telling you. Now, depending on what's going on something if your patient has a comorbidity that can use first line. Okay, so just keep that in the back of your mind, or else we're gonna worry and follow that flow chart that we went over at the beginning of class, okay?
Because it's increasing the production of insulin secretion, your chances of hypoglycemia are there, although it's a low risk. Headache, nausea, diarrhea, constipation. GLP-1s all end with tide, so they're all associated with pancreatitis and maybe associated with thyroid cell cancer and renal insufficiency. For contraindications, you have type 1 diabetes, and then any personal or family history with medullary thyroid cancer.
So if you remember thyroid, that, like, I don't need you to remember all the different specific types. Remember thyroid cancer, because of our adverse effect, I'm more worried about starting that in a patient who has a history or a family history of that, right? So I can increase their risk, and then they're more likely to now have that happen to them from my drug, okay? And then looking at, again, the GI stuff, nausea, vomiting, understanding too, I might have a different option to pick. Look at my liraglutide versus my linotide as far as like, where is it more prevalent, okay? You know, sometimes you see that where it's like, okay, if I'm experiencing a lot of this nausea and vomiting, what else can I give them besides this linotide? Oh, I can give them liraglutide if that's the side effect that they are experiencing. Remember, we don't always experience every side effect that is listed here. So you don't avoid something if that's the thing that you like to use. Don't avoid it until your patient comes back and says, oh, this is happening, okay?
So GLP-1s may delay the absorption of drugs due to the delayed gastric emptying. So just be cognizant of that. Sulfonylureas, consider decreasing the dose by 50% to decrease the risk of hypoglycemia. No added benefit with DDP or DPP-4 antagonists. So for monitoring, may decrease blood pressure and improve your lipid profile. Make sure you get baseline amylase and lipase for suspected pancreatitis. And again, be cognizant for difficulty swallowing, hoarseness, and neck masses for suspected thyroid cancer.
So what was your hint? That was dip with the lip, right? So this is the same side effect that we saw also in the chart. You're just seeing it again for the consistency of it, right? And then you see sulfonylureas being a problem, right? I have to decrease the dose again whenever I'm talking about sulfonylureas. A lot of our oral meds that we have when we're talking about diabetes, we don't have to worry so much about hypoglycemia. There's a very few. We worry more about hypoglycemia with our type 1 when we're dealing with insulin, right? So kind of separate the two things in your mind, and when you're studying, take your oral meds that can also cause hypoglycemia and pay attention to that, because we know that that's a big thing with insulin, but it's not so big with my oral meds, okay?
So we have the liraglutide, semaglutide, and dulaglutide. All three are available in pen form, and semaglutide being the only of the three that are available in pen and tablet form. You can take a look at the dosing, daily or weekly. The liraglutide for weight loss and indicated for weight management. It's also FDA approved for reducing cardiovascular risk and stroke. Just be cautious with that thyroid cancer again. Semaglutide is the FDA approved for diabetes management as well as for weight reduction and obesity. And then we have a note for dulaglutide, which is no dosage changes necessary in patients with renal or hepatic impairment.
So normally I tell you don't worry about the dose, but like we did with like our osteoporosis stuff, just know which ones I'm having to administer daily versus my weekly, right? And then the dosage form of this, remember which one is an injection versus a pen. Because if I tell you your patient doesn't want to inject themselves, we have another option, right? Where's my oral option? Where can I go? Oh, I have my semaglutide, right? So again, pay attention to not necessarily the numbers, but how often, the frequency that they're having to dose themselves, okay? Inject themselves.
Moving on to the selective sodium-dependent glucose cotransporter 2 inhibitors. They inhibit the SGLT2 transporter, which reduces reabsorption of filtered glucose, lowering the renal threshold for glucose, and resulting in increased urinary glucose excretion. Again, clinical use type 2 diabetes. Empagliflozin and canagliflozin, both FDA approved for reducing cardiovascular risk, with CV benefit potentially a class effect.
So what that means, and I know you know, but this is what they study certain drugs, right? And we may not have studied every single drug to know that this is a class effect, but what we're saying is all of these may potentially help and have that CV benefit. But these are the two that we have studied so far that we have enough data on to say they do have that benefit, okay? So this is a data-driven thing, and so because we haven't studied yet the dapagliflozin, we also think that we get that benefit also with the dapagliflozin.
Adverse effects, you have weight loss, obviously low hypoglycemia with monotherapy, increased urination, slight reduction of BP, hypertension in some. The bolded, we have genital fungal infections, which are more common in women, and UTIs, and may increase LDL.
So why do we have these infections that we see right here? What did we talk about the mechanism as to why you would see this adverse effect?
Sugar.
Right? And what if I have on tight clothes? What if I sweat a lot? What if I have poor hygiene? The risk of this increases. And sometimes with our patients, because they're getting so many fungal infections or UTIs, we stop these meds for them. Okay? So it's a very good med. It works very well, but that sugar is coming out somewhere, and this is where you see this increased risk. And remember again, low risk. Again, still with the hypoglycemia, still low risk that we're seeing.
So for precautions, your canagliflozin associated with increased risk of thromboembolic events, more likely in males with erythrocytosis. Just monitor your crit levels. Dapagliflozin may be associated with increased risk of bladder cancer. Just using caution. Renal dysfunctions, do not use canagliflozin and empagliflozin if the eGFR is less than 30, and if dapagliflozin is less than 25.
So, for your brain's sake, as long as you remember less than 30, you'll be okay. All right? And this is less than 30 is good enough. And then when I think about the dapagliflozin, I think about that it has the P in here, and so my bladder cancer, I have the P. So the dapagliflozin with the bladder cancer. Let's do our 10, because I don't want to interrupt whenever y'all are doing this. So do our 10 minutes, and we'll start that. Thank you.
Hey, just like have like a Montana 20-year reunion.
I love the best of both worlds. I like the climb.
Wasn't the climb like? Wasn't she did that on my side, not Hamilton though?
I didn't watch that. I was like 30 and I watched that. My Little Pony Road.
Holy line.
I didn't appreciate it. So complementary higher grade.
So it's a higher grade one, so you have much better grade.
I'm reading. I just bought it for
To add the 1,000 of them.
Yep.
And then
Oh, shit, that's a fucking boulder.
It's a little weird of a
Jesus, dude.
I'll put it on my door.
The door stuff?
Like, you wanna see like yeah, but look how big it is. I spent like you don't know how much I spent on little bracelet. For rare crystal. I want big pieces now. I used to just throw them on my bed and sleep with them. I heard, I hope you guys like
Yeah, a lot of it is like review.
I love it.
Alright, you know. Bye.
You say I know what I know.
I trust you, sir.
I do have trust. I do trust what you said.
Just wait for my review. I thought she was
I got you.
You still have it. Like if you're doing all the cardio, you still have it.
I think once you do it once, it's easier to stick it. Okay, so unstable angina, more frequent, favorite, EKGs, I'm looking for inverted T, depression, but as soon as it goes to elevation, then it's STEMI.
Yeah, but what makes it instant?
If the troponins are positive and there's no STL. I never knew that. I never knew that there was like
No, that's the animation. Oh, Lord. Mom, manuka honey.
And then once we get a positive outside,
That's more if it's prone to being elevated, that's fine. So you have some form of HCS, whether it's STEMI or STEMI. And that, confirm that will be. And then to the Catholic.
keep your breathing stuff to the cardiology. That just falls under. Is that just like patient learning to flexibility? I've seen like
Yeah,
I've seen depression.
Oh, excuse me, I'm so tired.
Depression. Stable anxiety. Now we're in STEMI. So just follows through.
So in the verdict mean that it's under the month. That's those many layers under that month layer you have a dash. So that one you don't want that because now you can't.
Yeah, I'm gonna give you a long name. At the very bottom, right, it's patient for TCSD.
And they need
So they had the worst ball, it's our better flow. Now they come in every month, this is the second game. This is like the third month, they come in and reevaluate their ads. This one is, if it's over 10%, so if you look at the top power, this is literally
December brand did his, and they approved, and he even skipped home.
Do you have like a clear or Joseph?
Those guys are very high.
You got 5 things. I mean, if you could sit there and like, if you can do the same memo, you can like tie it to their kilos, and you can adequately say like I really take this, that, and the other. Yeah, that's awesome. But it's
I'm good.
yeah, that's amazing.
I'm sure wherever we're at too, they might even have like, you know, especially so close to I don't even give a mom too, HRT. It's gonna be like, what do you recommend? What do you
Oh, no, it's not even HRC. It's so the Department of Nutrition send it to them, they evaluate it, and then after they evaluate it, then they send it to HRC. Because it's that piece of gear. So like in the end, like when I first did it, like they sent me that whole like you have to match your experience to test it. As long as you can match your experience, whether it's like PNC or what you've done, I mean, it's PMO and ag why
It's gonna be in somebody's garage. $60. Dude's garage.
Okay, group 10. Oh, sorry, I muted you. Go ahead.
It's okay, I get it. I'd mute me too. Alright, so so now coming up we have our dual action GIP and GLP-1s. I'm gonna lead with a really good quote here from one Alex Jones. I'm not gonna lie to you guys, okay, I'm kind of freaking retarded. So in order for this to make sense to me, I went ahead and looked up kind of a Barney style breakdown of what GIP and GLP-1 do. So GIP actually helps to improve your overall insulin sensitivity, whereas GLP-1 is going to help suppress your appetite. It slows gastric motility and emptying, and actually enhances additional GIP secretion. So that is kind of the rough nuts and bolts as to how this drug works. So you're stimulating both of these peptides simultaneously. Okay, so it's used in type 2 diabetes, Mounjaro for weight management and OSA specifically. And that compound is going to be your Zepbound. And then similar to the other GLP-1 agonists mentioned previously, adverse effects are going to be severe GI stuff, hypoglycemia, although the overall risk is low, and then we have our black box warning of potential increase in medullary thyroid cancer.
Okay, so I want y'all to think about something when it comes to the GI side effects. So when we look at this and we look at these drugs, a lot of your patients are going to want to stop the medication because of how bad the GI is. So you see it depends on your patient with what they end up having, whether it's constipation or diarrhea. They don't know what they're going to get, right? So you'll have some people who are taking the same exact med, they're like, oh, I have very bad diarrhea. The other person's like, oh, I have very bad constipation. So looking at those GI issues, it is a big, big, big thing that is happening now with a lot of people who are taking these. So when you also look at this, look at some of the other things that are happening, right? Hair loss. When I think about hair loss, think about the fact that maybe I'm not absorbing things as much anymore, right? Especially if I'm the patient who has diabetes. So now my hair is falling out, brittle, things like that. And then same things that we talked about before with that thyroid are still there, okay? I moved up so y'all can hear me just in case you're sitting here. Don't stare at me funny.
Okay, so then our contraindications, type 1 diabetes, because they don't have any insulin to secrete. And then, again, family history or personal history of medullary thyroid cancer, because as previously stated, we have a black box warning saying that we can increase our risk for that. Then our drug interactions. So because it is slowing down gastric motility, it is probably going to delay the absorption of other drugs. So if you're going to use them, then they have to be given either 1 hour prior to administration or 3 hours after, and especially for your more tightly monitored medications. If they have sulfonylurea co-administered, again, we're going to drop the dose by 50% just so we don't make them hype out and fall. Don't use it with a DPP-4 agonist. Again, no dip with the GLP, has no added benefit. And then also, interestingly, they can also decrease the efficacy of oral contraceptive agents. And then, again, just like with everything else, glucose levels are standard for monitoring, and then any kind of, or any indication of a thyroid tumor.
And I wanted to go back one so I can tell you something, because I know people notice things. So when you're looking at this, the clinical use of, you have your Mounjaro and your Zepbound, this is just pharmaceutical making money, right? because it's the same exact drug, same exact medication in them, they just branded them differently. And had one that says that it's for weight loss, one that says that it's for diabetes. So the same exact thing. So if you see this, that's why it's indicated there. Exam wise, I'm asking you guys, we're talking about diabetes, we're talking about weight loss, it will be on there for you to just know that both of these meds are referring to a GIP or in the GLIP combo. Okay? So it's just a branding thing, right? It's saying this one is specifically for diabetes, this one is specifically for weight loss. In actuality, it's the same thing. Okay? Money. Yeah.
And that top one, go like the diagonal, it's supposed to be dual,
On which one?
the first line on the top.
Oh, yeah. Yes.
So that,
Yes. The heading tagging, I've changed. Okay.
Okay, and then the money slide. So just like Major Hart said, as you can see from this lovely chart, it is literally the exact same medication. It would just be the difference in packaging and magnitude of dose. So tirzepatide, or pardon me, Zepbound specifically, is your weekly administration at a higher dose for obesity and OSA. And then your Mounjaro, again, weekly administration, but you're only going for a smaller dose, and that one is just for standard type 2 diabetes maintenance. You will start low with these and then titrate up. However, your Zepbound is going to be the larger dose because your patient is going to need to lose the weight in order to be able to sleep and not, have their neck or their tongue suffocate themselves, or so they have better cardiovascular outcomes in the end. And then for the type 2 diabetes for the Mounjaro administration, that again is just for the actual type 2 diabetes maintenance as opposed to a weight loss net effect. So it's going to stay lower than Zepbound.
Right, good morning, good afternoon. Alright, we're talking about amylin here, and then ultimately it's synthetic version pramlintide, alright? So if you're not familiar with amylin, it's a hormone, a pancreatic hormone that's released along with insulin, right? In our diabetic patients, the effect of the amylin is either going to be reduced or absent. So when we give them the synthetic version pramlintide, we're replacing that missing amylin hormone after meals, right? So what it does, it slows gastric emptying, it suppresses post-meal glucagon, it increases satiety, right? And then the result of that is a better control of post-meal blood sugar, and along with that can sometimes be weight loss as well. Right? Next slide. All right. So wouldn't recommend trying to memorize this entire slide, but just kind of think about where amylin fits in the picture here. Our other hormones that are active are going to be our insulin, our glucagon, and our GLP-1s. Like all that stuff works differently than amylin. Amylin instead is going to prevent sharp glucose spikes after meals by slowing how quickly the glucose enters circulation. Okay? And it mainly does that by limiting glucagon release.
So real quick, when we look at this, right, how many patients do you think follow this to the T? Right? Like, not a whole lot. So kind of keep that in mind, but make it also a big counseling point for you to tell them to do that. Okay? Administration matters because like we talked about with our rapid insulin, we said the same exact thing, right? Like it matters whenever we're giving it so that it can work. So this is that same concept of like getting close to how we talk about our insulin and the administration of it. Okay?
This slide kind of just goes over what we kind of been talking about the last few slides. Next slide. All right, so The biggest concern with pramlintide is going to be your hypoglycemia, especially in your type 1 patients. And then nausea is also common, and especially when people are starting it. And then the higher the dose, kind of the more nausea is going to be a problem with that. Contraindicated in patients with gastro problems or ones that do not know that they're going to be hypoglycemic. And then because it slows gastric emptying, it can delay the absorption of oral medication. So you got to kind of figure out what your other meds that patients are on. You got to kind of figure out what they're on, and then figure out when they need to take those along with your pramlintide, right? Next slide.
Oh, hold on.
Yep.
This one here, right? Why do you think you see more hypoglycemia in your type 1 patients? What do we know about our type 1 diabetic patients? Right? They don't have anything in their body, right, to produce those beta cells. So if I overdose or if I give them too much of something, that is why I can see this. So in my mind, when I study this, I think about insulin, right? I think a lot about insulin and it being kind of close to what we see in insulin, okay? So kind of put those side effects and things similar to what we're doing with our insulin, okay?
And to wrap it up, so it's given as a sub-Q injection right before major meals. Don't mix it with insulin. Use a separate injection site than what you did with that. And then if they skip a meal, skip the dose, right? We just talked about it, but starting therapy is reducing mealtime insulin by 50% for hypoglycemia. And then type 1 patients start lower and then titrate up. And type 2 patients start a little bit higher than your type 1 dose.
So anything that slows down motility, right? So even if I had any other drug on board, that would slow down motility. But now I'm almost pausing peritop, like no peritop, right? I'm stopping everything. If I compound it with two drugs that are doing the same thing. So it's always like that additive effect, like random side effects. Like if I had two things that cause hypoglycemia and I add them together, I'm more likely to see the hypoglycemia. So I won't give you the drug and expect for you to know that it causes that. I would have to tell you, especially if it was something that we talked about last semester, I would tell you, this causes that. Could you use these two things together? Give me a second. Y'all have your slides up, right? You can keep going.
You can just keep rolling.
Yeah, and then just say next slide when we go to the next slide, okay?
Okay,
So
so
everybody knows this.
next up is the alpha glucosidase inhibitors. Just like the name suggests, it is inhibiting the alpha glucosidase, which is an enzyme in your small intestine that breaks down carbs into simple sugars so your body can absorb them. And so essentially by inhibiting that enzyme, you're slowing that breakdown in your gut so the sugars into your blood more slowly after you eat, and you avoid the rapid spike in your sugar post-meal. So really these drugs are good for patients who are mostly controlled, your diabetic patients who are mostly controlled near their A1C targets, but they usually have a high spike right after they eat. So they know this, so they take it before that.
And that's why you're dosing on the next slide. You take it with your first bite, and it can also be titrated to how well your gut handles it, which is really the only adverse effect as well. And if you're choosing one of these for the GI issues, the carbose seems to be better, so has a lower percentage of all the GI upset issues. Your contraindications kind of make sense based on the adverse effects, because if you already have a short gut or IBD, you don't want to irritate your already messed up GI system. Same thing with cirrhosis. We talked about how most of these drugs are being metabolized by the liver, and the alpha glucosidase inhibitors, they've been shown to increase your liver enzymes, which is not good for cirrhosis. The note about Beano, since Beano is an alpha glucosidase enzyme, taking it with an inhibitor, they'd essentially be working against each other, so neither one of them are going to have very good efficacy at all. And as far as the individual drugs on the next slide, assuming we don't need to know all the specific dosages, they're pretty much the same, except for the max dose, which is weight-based. The biggest thing to pay attention to is the serum creatinine. If it is, basically if you have poor kidney function, the drug's going to accumulate, increase your adverse effects, and especially with your miglatol, which is clear renally. So you have miglatol and the carbose, and that's it.
Okay, sulfonylureas, aka insulin secret. I can't say that word. It's going to secrete insulin. So the mechanism of action, it's binding to specific sulfonylurea receptors on the beta cells inside the pancreas, which is going to force those cells to stimulate insulin secretion. Because of that, it's only used for type 2 diabetes. It should be titrated every 1 to 2 weeks. Caution for hepatic and renal dysfunction patients. It can be prone to tachyphylaxis, so make sure you're monitoring for reduced efficacy over time. Adverse effects, the biggest one for this is going to be the hypoglycemia. That's going to come into play with this a lot. It has a small weight gain that can be common. You can also see skin rash, some GI, hyponatremia, which is for the first gens, which we don't have listed in the chart, and any allergic reactions relating to sulfur. Drug interactions, we've already heard numerous drug interactions based around these. It also has a protein binding displacement, especially with the first gens. So warfarin, phenytoin, salicylates, it's going to potentially push those drugs off of their binding on the protein, so less efficacy and more free drug in the system. It's a CYP, it's CYP metabolized by CYP in the liver. And then avoid the clopramide, which is a first generation again, in patients with renal dysfunction or elderly, once again leading into that hypoglycemia. Like we talked about in the previous slides, GLP-1 agonist DPP-4 inhibitors, you'll need to consider decreasing the sulfonylurea dose by up to 50% because of that hypoglycemic risk. The hypoglycemic risk also is due to it's forcing insulin secretion from those beta cells, which can also lead to beta cell burnout and then eventually could create insulin dependence in a type 2 diabetic. So keep that in mind. Next slide is the chart. The biggest thing I took away from this chart, you can take a look for yourself for the starting doses based on elderly or non-elderly, the max doses. These should be taken with meals, generally speaking. You can also see on the right side the creatinine clearance levels. Most of them are pretty tolerant, up to 10 milliliters per minute, which is low. The glyburide stands out because it does, as a second generation sulfonylureas, have the highest risk of the hypoglycemia, and the creatinine clearance is up to
50 milliliters a minute, so it's not quite as tolerant for those. And then the one at the very bottom, glyperamide, is the safer option for renal dysfunction patients.
Do you think that we like these?
No.
That's why they're at the end. These drugs have so many side effects. They're old. This pen. They have a lot of side effects that come along with these drugs, right? And so a lot of the time, this is like a last line thing. You'll also see some people who are older who have been a diabetic for a long time use these. We don't typically use them often, okay? So kind of keep them in the back of your mind and understand that I want you to know why we don't use them. Can you still see them? Yes. Most of the time it's going to be one of these second gens. Glyburide, glipizide, you're going to see these sometimes, but just know, hey, especially if they come in with their chart and you see a lot of hypoglycemic events, this is a big thing as to why that could be happening to that patient, okay? So just keep this in your back pocket. They're effective drugs, they're good drugs, they just have a lot going on, a lot of interactions, got a lot of adverse effects. I don't love them a lot, okay? So when you're looking at this, know which drugs fall into this class and know what adverse effects you're looking at and contraindications you're looking at, which is why we don't like them, okay? All right, our last one that we're going to look at is going to be your meglitides. When we're looking at our meglitinides, when we're talking about these, again, that taking it with food is going to be very, very important. Your mechanism of action, similar to our sulfonylureas, not in the same exact place. So same kind of mechanism as far as how we're trying to stimulate that insulin secretion, but not in the same exact site. And then it must have that glucose. If glucose is not present, it will not work, okay? I want you to note on this one, remember when we looked at that chart, which we're gonna go over one more time before we leave today. But when you look at that chart, you see that this is not a treatment option that we have in the guidelines anymore, okay? So it's something to just know that you may still see people who are taking it, but it's like far down, right? So for your purposes and you potentially prescribing this, no, you might see it, just know that it exists, okay? Know what drugs we're gonna talk about here. These are your two that you'll see, your neglitinide and your repaglinide. Again, that's all I need you to know from this, is the drugs that fall into this drug class, okay? Your TZDs, when you look at your TZDs or your thiazolidinediones, these are insulin sensitizers, so that is essentially what your mechanism is, right? It's enhancing the sensitivity to insulin so that our body can respond to that and help our patient who has a lot of the glucose and the sugar floating around, right? You look at your other thing that's kind of unique to this, which we haven't seen, is that peroxisome proliferator activator receptor, or your PHARM gamma. This is, again, something that is helping us increase the sensitivity that our patient is needing, which is why they are a diabetic patient. You see your pioglitazone. When we talk about this, I'll make you guys focus on this in another way, but you also see that you have some agonistic effects there with your dealing with the PHARM gamma there. Type 2 diabetes, of course, because that's what we've been talking about this entire time. Adverse effects, we talked about weight, right? Weight gain, again. So one of those ones that, again, we don't love to use often, but it is something that we do see prescribed still. Fluid retention and edema, who do I think that's important for? My heart failure patients, right? Because we're already worried about the symptoms that they're going to experience with these meds in general. So avoid these meds when we're talking about our heart failure patients, MI. So just think cardiac issues. Try to avoid it. My patient who is old and brittle, potential osteoporosis, what do I see here? An increase in my fracture rate that could happen, okay? And then looking at this, the hepatic failure, just understanding that it is something that can happen. It is not very common. We would discontinue the meds, start them on something else to try to control them. And specifically, again, with our bladder cancer, right, we have P again, so pioglitazone with the bladder. increased risk of bladder cancer. So when you talk about this, what we see with this class is that there are a lot of, again, side effects. It's a nasty drug. It's not an elegant drug, okay? So kind of on the bottom of the list of if you had to pick meds, this is on that's going to be down there at the bottom because we see all of these different side effects. Looking at your precautions, we already talked about these because we said that our meds could cause these things to happen. So of course we want to be cautious in using them in these patients. The difference between your precaution and your contraindication. If I ask you something like this, it would be that you're going to avoid it in anybody who has heart failure. I don't need you to remember 1 and 2, which is like not as severe as class 3 and 4, the heart failure. Just know that we're trying to avoid them in general and you will be good enough, okay? Your bladder cancer, so if I have a history of it, I'm worried about it, especially with my pioglitazone. So remember your bladder with your P. And then your interactions, again, increasing the risk of somebody who has heart failure, right? I could cause them to have an exacerbation, and somebody who has an MI, I could potentially have them have another one. So this is more so seen with your rosiglitazone, okay? Monitoring, duh, right? We're monitoring their A1C as they continue to come in to see us with any of the meds that they're taking for diabetes. That is what we are trying to get controlled. We're trying to lower the A1C. Also, because we said that we could have that hepatotoxicity, I need to make sure that you're getting your LFTs, cardiovascular, right? Because I can have that MI, I have my heart failure patient. So making sure that you're monitoring the symptoms that they have as well as your lipids. And then again, your rosiglitazone with your heart failure, increased risk there. Here are your 2 TZDs that we have, pioglitazone, rosiglitazone. Again, just remembering this one is more so we're worried about bladder. This one we're more so worried about our cardiovascular events happening, okay? So that's the difference between these 2 medications. Again, dosing, don't worry about that. We will see when they start to pull some of these things off of the market because that's what happens to these. They will go off of the market when we start to see a lot of increased cardiovascular events and things like that. So last line types of things. Our medications that can increase blood glucose. So there's lots of different meds that we can put our patients on that would make their diabetes worse. We have talked about some of them last semester. So when we look at this, and we talked about some of them this semester, and we're going to talk about more of them. But you have beta blockers, right? Your steroids, diuretics, thiazides, loops, niacin. I don't need you to remember all of the things that are happening here, right? All of them are going to increase the glucose levels in your patient. I don't need you to know what the mechanism is. I just need you to know, bless you, that they have these drug interactions with these things, okay? So that is it. Not all of the potential mechanisms and the consideration for management, I don't need you to know that. Just that they are I can increase my glucose levels with these things. Everybody good? Okay, one more time, I want to go back to this. Because I still had questions. Okay. If you feel like you got it, that was the end of class. I'm going to post the memory jog under there. I think it might already be up there, but the memory jog on there for your summary. Again, I'm available if y'all need me. You can text Major or Colonel Rogers, keep calling him Major, to tell him like 5 minutes. Okay, so to clarify this and what this looks like, right? Your patient is diagnosed with diabetes. They came into you and they said, I'm here for my checkup. You did your several things. You have confirmed that they had diabetes. Okay, remember on the test, I have to tell you what they have. You're not diagnosing your person. Your persons don't have diabetes, all right? We're treating them, okay? I also will have to give you your goal. You can't talk to your patient because it's your computer screen. I will give you what your goal is, all right? So this number is going to be given to you, the 6.5, the 7, or the 8. Now, I'm going to tell you somebody had a lab, right? I got their A1C, and their A1C was, let's start with, my goal is 7. I told you that my person's A1C is 9. Are they monotherapy or are they dual therapy? Why are they dual? They're greater than 1.5 of this 7 that I gave them, right? So this is set. Now your second step is to say, I know what my goal number is. What do I need to do? Am I going here or am I going here? I got two options, okay? So if I am less than 1.5, I'm monotherapy. If I'm over 1.5, I am dual therapy. This is not in order, right? Now you know about these drugs. I can pick any of them. Some are not fantastic for me to pick. I like some of these, right? So I can pick anything that I want for my second line. You need to look at your patient and say, is there a contraindication to it? Is there a reason why I can't choose one of these other drugs as my second med, okay? What if my A1C was 11?
Insulin.
It's true. Insulin, right? So I have my metformin and I have my insulin because my A1C is greater than 10. Make sure that you remember if that A1C is greater than 10, that is high, right? What is my goal? What do I want them at? I want them at a 7 most of the time. This person came in with a 10, they got a lot of work to do. If they came in with a 12, they got a lot of work to do, okay? You can also have somebody who came to you and maybe their A1C was 9 at one point, and now it's at 10. Now it's at 11. You can always add on insulin whenever that A1C is getting out of control, okay? You can try to add on oral options first, but you may have some of your patients where they do need to end up on insulin, okay? So I give you that they have diabetes. I give you what their goal is. Your job is to say, am I 1.5 over, yes or no? If I am 1.5 over, yes, dual. If I am not, then mono. This is a separate thing. Your comorbidities is something completely different. So if your patient presents and they have ASCVD or weight loss, I can pick either of these things to start with. I can pick my GLP-1 or I can pick my SGLT2. Either one, okay? If my patient has heart failure or CKD, this is a must that I am starting with a SGLT2. And then I am building on for them. Same rules apply with what you don't stack that we learned as we went through, right? So if I had this person and they were on a GLP-1 and I got to this point, which remember I told you I'm going to stop here if I ask you a question, I'm not going to go that far. But if I did have this, which is the question that some of people are asking for completeness, I'm going to have to shut them off of this GLP-1, right? So then they would just have an SGLT2 and potentially a DPP-4 inhibitor. Okay? Because I still have the same rules. I can't give these two things together. All right? When you look over here, when you're talking about your insulin, understand that this looks very complex with how you could potentially give this patient insulin. You could have them on some of these meds and they're still going the opposite direction. Their A1C is going the opposite direction. You can always add on insulin. Be careful with insulin because you can also cause hypoglycemia. Right? So sometimes, reality, I'm going to pull off some of these meds if I'm doing that. Okay? Because I don't want to increase the risk of hypoglycemia. Are we good with the chart? The chart is important. You're going to see the chart again, I promise. Okay? I will be around if y'all need anything, of course, text, call, whatever you need. Okay? Thank you.